Yeah. So I'm Dr. Swapna Nair, and we are gathered here today for a session on refractive surgery complications, the graver complications rather, that may happen long after the primary procedure without any prior indication most of the times. So without much delay, because our speakers have commitments otherwise also, I'll start with Dr. Rajesh, who would be talking on post-LASIK ectasia.
Thank you, Dr. Swapna. And I'll be talking about suspecting and managing corneal ectasia post-refractive surgery. Now, there are two issues. One is, of course, suspecting corneal ectasia post-refractive surgery, and the second is managing once you have detected it. Now, for suspecting corneal ectasia, there should be something related to it. I mean, it should begin with the suggestive symptoms so that there should be some degree of suspicion. And suspicion becomes strong when you examine the patient. And it gets established by doing corneal topography or tomography. Now, the typical suggestive complaints can be gradual progressive painless diminution of vision. Then BCVA with glasses may or may not be attained up to 6/6, ghosting or shadowing of image, or prior history of corneal refractive procedure. And on clinical examination, you get to see slit lamp appearance of a corneal thinning in the area of ectasia, unstable topographical steepening, more than one diopter for each month period of follow-up, documentary evidence of reduction in CCT, 30 microns for each 6-month period of follow-up in the area of steepening, unstable refraction, and posterior corneal steepening. Now, all these things require a proper documentation, and that is why it is said that, you know, many times we get an ectasia suddenly comes to us, and we are not, sometimes it gets missed, or sometimes we get it in slightly advanced stage, because if the documentation is not proper, then one may not detect it at the earliest stage, and all these things can be done if there's proper documentation. The suggestive features, as I said, there can be loss of more than 2 lines, refractive change, more than 2 diopters, spherical equivalent, topographic corneal steepening or toricity of more than 1.5 diopters, and central steepening. So, as I said, that after examination, you will go for a pentacam, you will go do a tomography, any tomography, and then you will start looking at the front and back surface, the elevation pattern, the keratometric patterns. You can see here 44 and 47.6, which is highly suggestive, thin cornea. Then all these factors are important when you are detecting the map. As you can see here, the skewing of the axis. You can see here, if you draw the axis, there is skewing of more than 21 degrees if you extend these two. So these factors are there, anterior and posterior elevations are there. So all these factors are there. And then, of course, in the other map, in bad map, what you Bellin embryo enhanced ectasia display, you get to see these red areas. And then, of course, the D value is suggestive. Then the PPI, ART max, all these factors, they are suggestive of post-LASIK ectasia. So if we get to see, as I am showing here, ART max is 207, which is very much highly suggestive of post-LASIK ectasia. Now, once you have this diagnosis, you have to manage the case, and management modalities depend on 2 things. One is you halt the progression, because once there is ectasia starts, the weakening of the cornea starts, the ectasia keeps on progressing. So you have to halt the progression. And then, of course, visual rehabilitation has to be done. And visual rehabilitation can be done by glasses or by contact lens or ICRS or any type of keratoplasty. So cross-linking is the mainstay as far as the management or halting the progression is concerned. And cross-linking is done in this manner. You can do a standard technique, you can do an accelerated technique, you debride, but epi-off technique is something which is always accepted. So epithelium has to be removed. So central 7mm epithelium removed. And then you put riboflavin every 2 minutes, and then for 30 minutes, and then do cross-linking for 30 minutes. If you're doing accelerated protocol, then the protocol will be different. A lot of work, a lot of talk is going on about customization of CXM. Now, this is a meta-analysis on cross-linking in post-laser vision correction ectasia. And they found out that the uncorrected distance visual acuity remained stable, but significant improvement in corrected distance visual acuity was seen after cross-linking. The topographic parameters showed less positive response to CXL compared with keratoconic corneas, untouched virgin keratoconic corneas. And stabilization of corneal thickness was observed in all studies with maximum follow-up period of 6 to 2 months. So the basic idea is this: what this meta-analysis means is this, that there will be some degree of stabilization, there will be some degree of effect that will definitely come, but it will not be as good as a primary keratoconus. Why? Because we all know that cross-linking works in the anterior two-third of the corneal stroma, and the anterior two-third includes the flap as well, and flap does not contribute to the strength of the cornea. So this is definitely one factor which an explanation which states that, you know, cross-linking may not be as good in post-laser vision ectasia, post-LASIK ectasia, but definitely it has some effect. As far as visual rehabilitation is concerned, contact lenses are something which can be used. SOPER design is the standard bicurve design, and Rose-K is the multi-curve design. A good centration, movement, and coverage, and a 3-point touch fluorescein pattern. So this is what you get in an RGB contact lens fitting when you fit the lens in a keratoconic cornea or a post-LASIK ectasia. The good centration, a movement of near about 1 to 2 millimeters for the tear exchange, and good coverage of the visual axis with a 3-point touch. Some patients do not tolerate a contact lens, and that is also why they undergo laser vision correction. So in those cases, you can give piggyback lens or a hybrid lens. And if the ectasia has advanced, then you may have to go for a mini scleral lens, because but most of these post-LASIK ectasias, you do not require mini scleral lenses. Why? Because the post-LASIK ectasias more often than the primary keratoconus have a slightly on the cone on the central side, rather than, you know, in a primary keratoconus when you get it in inferotemporal and inferonasal more often. So that is why the corneal contact lenses, they are quite effective in these, but sometimes you do require advances. Intracorneal ring segment is quite successfully used in post-LASIK ectasia. It shortens the corneal arc length, and it is inserted at approximately 2/3 the corneal thickness. This is how it is done. Now, intracorneal ring segment along with cross-linking is one modality which is very effective in post-LASIK ectasia. And I guess the indication for ring segment, the first indication will be a post-LASIK ectasia. And this is how the track has been created by the femtosecond laser. And then you just open the initial part of the track on both sides. And then you place this ring segment made of PMMA into the track. You put it on both sides and then put a suture and then debride the epithelium in the central part of the cornea within the ring, and then put fibrin glue and then do cross-linking. So this is how it is done. This is the post-operative picture. You can see the cut section OCT picture. And this is the post-op picture. So ring segment have been used with good effect. Now, this is one study on indications for intrastomal corneal ring segment in ectasia after LASIK. And they concluded that the best indication for ICRS implantation for the treatment of post-LASIK ectasia was a loss of 2 or more lines of CDVA after the ectasia had developed. The reason is this, that in some of these cases, if the ectasia may be there, but if with glasses there is the loss of vision is not there, then the patient satisfaction is not much. And if the vision is good, sometimes it has been seen that even after ICRS, there is loss of 1 or 2 lines. So that is why it is indicated best in cases wherein there is loss of 1 or 2 lines. Then another study which stated about single segment and double segment intacs for post-LASIK ectasia, and it concluded that if the astigmatism is significantly high, then one should use a single segment. But if the spherical component is predominant, then one should use a double segment so that it reduces the spherical part. But more often what I have noted in post-LASIK ectasia, we may have to use a single segment to reduce the astigmatism. Toric ICL is another option. After doing cross-linking, you can put a toric ICL, because these patients, they are not very keen to wear glasses. That's why they are undergone LASIK. So they again want to get rid of it. So if you do a cross-linking, and after that, if it is stable, then if the cornea is stable, then you can go ahead and put a toric ICL as well. Keratoplasty is definitely the last resort, and every other means fails in advanced ectasia. DALC is something which is indicated. I won't go into the surgical part because of paucity of time. Prevention is something which is really important. The risk factors have to be identified, like major risk factors and minor risk factors. And in major risk factors, abnormal topography or tomography is something which is there, like keratoconus or form first keratoconus. It should be detected before you do a laser vision correction. And a minimal, there's no magic number for residual bed thickness. 250 or 300 is accepted, but even above 300 ectasia has been seen, and even below 250 ectasia has not been seen. So maybe corneal biomechanical index is a factor, maybe some other factor is there. And there are a couple of studies which have compared the PTA, because we have given a lot of importance to PTA. What they say that topography is more important than PTA, and that is the most of these studies. The crux of all these studies is that topography is the key when you are selecting patient for laser vision correction. So in conclusion, it is most important that patient selection is very important as far as the laser vision correction is concerned, if you want to prevent post-LASIK ectasia. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. That was very exhaustive, and I think it covered all aspects of post-LASIK ectasia and all types of management. Thank you very much for your valuable time and for this exhaustive talk. Thanks a lot.
If you allow, I have to go to the other
Yeah,
side.
sure.
Thank you.
So now we move on. I think Dr. Mahipal is also in the OPL session. So I'll go to my talk, which is on cataract management after LASIK surgery. So cataract usually happens quite a bit long after LASIK surgery. So it is a relatively late complication. And when it does happen, it does pose a lot of problems, a lot of challenges rather, which were more earlier, and now as time has gone by, as technology has developed, it has become better managed. So what the challenges are is basically that you're dealing with a patient who has corrected his vision using LASIK so that he could see better and get rid of glasses. Now, it is this patient that's presenting to you with cataract, and obviously he doesn't want to go back to his glasses unless absolutely necessary. The second thing is that he has high vision expectations, because after LASIK, his vision became absolutely clear. What he was not seeing over the ages, he started seeing, and he expects the same kind of result after LASIK and with the minimum possible, after cataract surgery and with the minimum possible aberrations. Then, of course, what the surgeon faces is the multiple types of inaccuracies in IOL power prediction. Now, such a patient may also, the surgeon should keep in mind that such a patient may actually need an entire series of bioptics procedures. The patient had undergone laser refractive surgery or a phakic IOL before, and you're prepping the patient for a cataract surgery, but always keep in mind that following the cataract surgery for a residual refractive error, you may need to go back to a refractive enhancement, either a topo-guided one or a laser vision correction for a small amount of myopia, hypermetropia that may be residual and may be annoying the patient. So one should be prepared for that. Now, what are the sources of error in intraocular lens power calculations? This has been much discussed even during this meeting. So we know that the corneal power is not what it shows up on topography or keratometry, because the central cornea, which is actually mapped by all the keratometers, the central 2.5 to 3 millimeters of cornea actually is much more flatter if it has been a myopic treatment, much more steeper if it has been a hypermetropic treatment than is assumed by the topographer. And of course, the anterior cornea to the posterior cornea relationship has changed from the flattening of the anterior cornea and the thinning of the cornea. And because of all these reasons, again, the formulae that we traditionally use, that is the regression formulae, the theoretical formulae, they don't hold good because they also depend on these assumptions of keratometry. So what do we do next? Of course, there have been measures because of the sheen flow imaging, OCT guided axial length and anterior chamber measurements, and multiple formulae that have come across using historical methods or double K method, Malani, you name it. And a compendium of these can be found at the ASCRS website in the ASCRS post-refractive surgery IOL calculation, which is different for RK, myopia and hypermetropia, and gives very good results. I have found the same results when using the Barrett's Universal 2 formula also, especially with all the latest biometry instruments, where even a regular lens power calculation quite often matches what is provided by the ASCRS website. Then certain biometers also have post-refractive surgery calculators, which again give lenses corresponding to what you get from the ASCRS website. So now once what lens to use has been decided, the planning of the surgical technique takes place. Now, why is it important that you plan a bit? Because now here you're talking about a cornea that is not intact, that's not pristine. So you have lines of dehiscence if you're talking about radial keratotomies. So usually you see 8 of them, but they have surgeons earlier who have done much more, and you have an extremely weakened cornea, which has gone down, let's say 80 to 90% of the corneal thickness. And therefore any invasion has to be very guarded. Of course, you have flap margins in LASIK, and you should always identify the hinge, so where you know that the flap is attached to the rest of the cornea, and try to avoid traumatizing the flap or elevating the flap by mistake during any of your corneal incisions or opening up of the side ports. Then, of course, the phaco parameters, though I don't keep them always very low, you need to be a bit guarded in that respect as well. You don't need to, especially in a cornea which is actually a virgin cornea and only 10%, and then a scarred cornea in the rest, as in a radial keratotomy, you wouldn't want extremely high intraocular pressures with a lot of turbulence in the anterior chamber, just to prevent the incisions from dehiscing. And dehiscence has been noted in many cases. Regarding fluid in the interface, this can sometimes happen if the intraocular pressure is able to drive fluid into the interface, which is always a potential space even years after the flap has healed. Then, of course, IOL centration is very important, especially if you're using a non-unifocal or a multifocal intraocular lens in these procedures, where the visual axis has to correspond to the central axis of the lens. Now, this is a post-refractive surgery cataract patient, and this is a wavefront imaging of the patient. You can see the high order of astigmatism and the higher RMS values. So here the lower order errors are highlighted, and equally present are the higher order aberrations. So this is what I meant by placement of an intraocular lens and exact centration. You can see how the centration has to be marked in this patient by using the Purkinje images and the center of the visual axis. So usually in Varion and such imaging instruments, you have a central line, and the Purkinje, the anterior and the posterior Purkinje images have to correspond to the center of the line, which makes sure, and this has to correspond to the central zone of the lens, which makes sure that the lens is centered so that the aberrations are minimized. Now that would result in post-cataract surgery, better wavefront, where you can see that the aberrations have considerably reduced. Now, what do you do if the ablation itself, the primary ablation itself, is decentered? So here you can see an ablation that is pretty decentered, and there is flattening of the peripheral cornea, paracentral cornea rather than central cornea. This is a post-relax patient, and in these cases, you may need to warn the patient of a topo-guided enhancement following cataract surgery, where you just need to smoothen out all the irregularities of the cornea to provide a low aberration vision to the patient. Now, this is a case of radial keratotomy cataract, and you can see all the markings on the cornea that look pretty scary from this, just paracentral region all the way to the periphery. So here, what I'm showing over here is the wound on the cornea. You can see that the wound has to be placed between two of these scars, so that, and a bit more limbal than cornea, so that you don't at any point during wound making touch these scars on the cornea, so that chances of the scars dehiscing are minimal. And in case there are more lines or more scars than 8 on the cornea, that may be better to do a scleral tunnel. That should be an option kept in mind. So here is a radial keratotomy patient who was undergoing flax, and you can see how the wound is placed between two of the radial keratotomy marks. The phaco parameters are a bit on the lower side, and the phaco is a bit in slow motion because I don't want to create too much of turbulence in the anterior chamber. Of course, the flax procedure has caused the lens to be pre-chopped, because of which the energy used and the manipulations have reduced rather than when it's done in a full-fledged. And the cataract is not of a very high grade, as you can see over here. And now here comes the placement of the intraocular lens. What is to be noted here is the centration of the lens. Now, because the rhexis is an automated rhexis, it is perfectly at the center, and placement of the lens is very much aided because of the good coverage from all sides by the rhexis. So it lands typically in the center itself. So this is how the post-operative picture looks like. Now, what do you do when you have an ICL with a cataract? So in a phakic IOL with a cataract, you may need either an ICL explantation, removal of the cataract and replacement with an intraocular lens, or you can retain the ICL and then continue the surgery and put in an intraocular lens where the ICL acts as a piggyback lens for the intraocular lens after the end of the surgery. So now here is a post-ICL cataract, and before the cataract procedure, the ICL is being removed. Now here, what you need to take care of is not the lens underneath, which you need to do in an eye without cataract, where you're replacing the ICL because of a high vault. On the other hand, here you need to take care of the cornea just to make sure. So there should be a good coating of viscoelastic between the ICL and the cornea. And the ICL can usually be removed by the same 3 mm incision that it was inserted through. And after cataract surgery, an IOL can be placed exactly in the same position. Now, without explantation, so here you have an ICL sitting there, and because the patient was a high myope and desired multifocal intraocular lens, so I retained the ICL. Again, the cornea has to be taken care of extremely, and all the maneuvers are done in such a manner that you try not to hurt the ICL, not to damage the ICL, because you're trying to retain the ICL inside the eye. And coming from the sides, you can see how the phaco port as well as the side ports would go exactly where the optic of the ICL ends, avoiding the haptic. And the phaco parameters are kept as normal here. So after cortex aspiration, the intraocular lens is placed in the bag underneath the ICL, and then the ICL is tucked back into the sulcus. So it was sitting in the angle so long as the surgery was taking place. So once the visco is thoroughly aspirated and you're sure there's no visco in the interface between the phakic IOL and the IOL, once that is ensured, then the ICL is tucked back into the sulcus, like you see over there. Centration again is maintained using the Purkinje reflexes. So meticulous planning in each of these conditions, whether you're dealing with radial keratotomy or whether you're dealing with LASIK, PRK, or a phakic IOL, meticulous planning pre-operatively, proper calculation of the intraocular lens, and exactly how you intend to follow up the patient in case of a residual refractive error should always be kept in mind. And suppose you try to keep the patient a bit myopic because they're always used to seeing near, especially a short-sighted person. But always remember that sometimes it may be easier to correct a hypometropic refractive error in an already thinned cornea. So even if the patient gets to be a bit hypermetropic, there's no need to be dismayed, because it may be easier and more intelligent to clean off a bit from the peripheral cornea rather than from the already thinned central cornea. Thank you very much. So yeah, carrying on with our session is Dr. Namrata here. I think ma'am has not joined yet. Titial sir, would you be willing to present next?
Yes, I'll do it.
Yeah. So we'll be talking on anterior segment trauma after a refractive surgery, which is not very common, and with vast experience as his, he has great knowledge in how to manage such cases.
Yeah, first of all, thank you, Swapna, for getting me into your instruction course. I know complications are quite uncommon in post-refractive surgery, but if they happen, they can be managed, as you rightly pointed out, very effectively also. No financial disclosure, nothing can happen in a complication type of presentation as such. As you rightly said, refractive surgery is one of the most commonly done procedure in the body, and it is so widely done world over in large number. And any refractive procedure in cornea can weaken the entire ocular structures. And with a minor trauma also, sometimes you can have a serious sight-threatening complications also. They can happen anytime post-surgery. It can happen after many, many years of a surgery also. I think once you have a history of injury in a post-refractive surgery patient, you have to do a very comprehensive examination, look for angle areas, intraocular pressure, lens status, and the posterior segment examination is very, very critical for all these patients for giving them an outcome subsequently. As we know, these patients had undergone refractive surgery to have a best visual quality, and they think after this trauma also they'll regain the same visual quality. Therefore, I think the counseling part is very, very important for these people. So this is a gamut or refractive surgery you can see. Let me talk about incisional surgery, which is not so common now, but you still have radial keratotomies or some sort of incision which we do in a intracorneal ring segments, where with the trauma sometimes the ring can extrude out, or sometimes it can go into the anterior chamber also. So that type of complication you can see, and those managements are quite simple also. But radial keratotomies, the things can be totally different. And you know that sometimes they can have multiple incisions, and they may be more than 80% depth. And I know that larger the number of incisions, more than 12 incisions, and the longer the incision reaching up to the limbus will have higher chances of weak coats. And with the injury, they can open up like a flower petals. So it is a petaloid type of opening which can happen in a post-RK incisions. And unfortunately, many cases have involvement of optical zone also. So this is a young patient who had fight with somebody and had an injury to the eye. He'd undergone radial keratotomy almost 19-20 years back, and he had a petaloid opening of all the incisions. So we had to put sutures to every incision. And sometimes, as you put one suture into one particular incision, other incision opens up. So you may have to do a bursting type of suturing also in these cases. So this is after a few months. You can see entire cornea got decompensated. And this patient ultimately would require a sort of a keratoplasty to give him some vision back. You can see how much edema is there after 1 month of surgery. You can imagine RK per se will cause endothelial compromise situation. And with the injury opening up, incision opening up after injury will again decrease the endothelial function. So these patients may require an optical graft subsequently. This is another example of a patient. In fact, I had reported a similar case here where the incision got infected with staphylococcus after injury, and this never healed unless we put a bursting suture all around to compress all the incisions, and subsequently it will heal. So RK can be very, very devastating if there's an injury to the eye, especially closed globe injuries, and entire eye can open up and things will become very, very difficult as such. Let's talk about flap-based procedure, which is so commonly being done across the world. LASIK as such. It can be a microkeratome-induced flap, or it can be femtosecond induced flap, but all can get dislodged. They can get avulsed. There can be a flap tear. More commonly, flap stria is very, very common immediately after surgery, or even after a long term after surgery also. And if you have an injury, there are high chances of epithelial ingrowth happening in these patients. Sometimes you can have a scarring also. So this is one patient you can see a flap got displaced and epithelial ingrowth has happened. This is a patient after a total flap melt, there's an infective insult also. And these are epithelial ingrowth which has happened post and the stria, which we saw after almost a month of surgery in this particular patient. You can see the subcutaneous hemorrhage. So this is one incident where the flap got totally dislodged. You can see here the flap is pushed towards the optical center area, and there's epithelial growth also. And as I said, the risk factor may be if you do a microkeratome flap, it has a lesser adhesion than a femtosecond LASIK flap. So you may have more chances of flap getting displaced. Sometimes you can have more folds. You can see normally folds will be radial. You can see folds here is a tangential because there was an injury to this particular patient. So all this is going to cause decreased vision, decreased visual quality, and irregular astigmatism will develop in such cases. And the workup has to be very thoroughly assessed. The cornea, the tear film, ocular surface, the quality of vision has to be assessed, and always look for a other eye which can also have the same problem or maybe better. Accordingly, you can enhance your outcome. Anti-segment OCT is very useful in these cases to assess the entire length of right from epithelium to a deeper stroma part also. The management is difficult sometimes because the flap may be totally wrinkled. So you may have to do as early as possible. You can flatten the entire flap, remove the epithelium first, and subsequently do the assessment. So first you have to need to see what is the edge of your flap. So once you identify the edge, you can lift the flap edge, and OCT can also give you a lot of guidance. Lift the flap, iron out the flap, remove the epithelial ingrowth, and subsequently flatten this entire area. And mitomycin C should be used in these cases, especially with the epithelial ingrowth being there. So this is a case after we intervene. This is after 1 month. You can see absolutely normal cornea. If you intervene early, you can regain the visual acuity of these patients. So these are other type of flap complications. You can have folds, which can be micro and macro. Micro folds, if they are not affecting visual acuity, may not do any intervention. But normally, post-injury, they are macro folds, and these folds have to be taken into making them smooth. As I said, two important things are there. When you have a macro folds, they are there for a longer period. You have to remove the epithelium first totally before you try to lift the flap. Remove the epithelium, then lift the flap. You can iron out the flap, or you can make it hydrated so that ironing is better. And if needed, you may have to put a sutures to put the flap in right condition. Sometimes you may have to put a glue also, especially if your track remaining there in these cases. So this is one example. This patient, I recently saw it in my clinic. The patient had undergone microkeratome assisted LASIK almost 4 years back. Unfortunately, he had an injury almost 1 year back, and because of a COVID situation, he could not come to the hospital. And you can see his vision had gone down to almost 4/60 in this eye, which had an injury. Other eye was almost normal, and with the best corrected vision was 636 only with the irregular astigmatism. So this is a picture here. You can see this is the edge of a new flap now, which has got totally displaced to one side, and this is the area which is exposed because the flap got displaced. And this area has already epithelialized with a little bit of stromal, you can say, opacity here. And this is a large epithelial ingrowth being there in this particular page. This is a retro illumination picture of the same patient. This is the new flap edge. See the folds here, and this is opacity which has developed in this. So I took this patient for a flap amputation because nothing would work on this patient. If you see the pre-op topography, so the steepness, cornea is also thick because there's a epithelial hypertrophy as well as the flaps getting crowded there. This is the OCT picture of same patient, epithelial ingrowth, and this is the folds in the stroma also. So this is on table. You can see what I'll do. I'll try to remove the epithelium first. IOCT picture clearly delineates the epithelial growth and the spaces created underneath the flap and the stroma here. So once I take out the epithelium here, I'll delineate the flap S with the Sinskey hook. Once I delineate, I'll go through and release the entire flap. So luckily, this was a superior hinge flap. I could remove the entire flap in one go. This area where you have epithelial growth will be little densely adherent. Subsequently, I can do a flap rhexis, and you'll see here. So once I delineate the edges, I'll do a rhexis, remove the epithelial ingrowth with the scraping here. And this will work out for this patient. You can see this is a large flap here. So I'll remove this epithelial growth. A little bit of hypertrophy which was happening in the stroma will also be taken care of. Use mitomycin C 0.02% for at least for 30 seconds to 1 minute. You can see it quite clear now. Though you can see a stromal area still getting little folds. You can see here in the OCT also. Put a bandage contact lens. And this is the next day picture. This is the cornea next day, and it looks quite smooth. And the vision has also improved to 6/24, and 6/12 is the corrected vision. And this patient topography wise, this was pre-amputation, and this is a post-amputation. The cornea has become much better, and vision also would improve in next few months. If needed, we can do an enhancement for this patient. Epithelial ingrowth post-trauma is normally associated with the folds and displacement of a flap, but they can be taken care of by various ways we described. This is one patient I saw had a sort of sharp injury to a sharp knife injury to a cornea, which she had undergone LASIK, and see how much scarring is there right in the optical axis with epithelial ingrowth also. So this patient, again, I had to do a flap amputation and do a anterior lamellar keratoplasty to help this patient. So these are a wide variety of injuries which can happen. This is a post-phakic IOL patient, where with the trauma, one of the haptic had come out in the antechamber, and this can happen with the ICL patients also. And treatment will be early reposition with taking care of inflammation, glaucoma in this particular patient. This is after reposition of same patient. And these are cases, I should do a lot of these cases earlier, and this inflammation can occur with the injury, and you have to redo these patients. And resurgery means more endothelial damage, more chances of glaucoma in these patients and cataract. But luckily, we didn't have many patients. I had done around 400, 500. We saw around 8 patients getting dislodged with the trauma. Sometimes you can have a cataract post-injury with phakic IOLs also, and they may have to remove that. Dr. Swapna nicely talked about how to do cataract surgery. This was patient, I did a femtosecond surgery for this patient. Underneath the ICL, you could do a capsulotomy and nucleus softening also. Surgery becomes quite simple. And the ICL can be removed subsequently without opening the incision. It comes out through a 2.2, 2.8 also. And you can do a surgery subsequently very effectively also. So cataract surgery is not difficult post-refractive surgery. Yes, IOL power calculation will be challenged in an RK patient, not in cases with ICL. They are almost similar. To summarize, you can have incisional surgeries, you can have a flap, you can have a lens-based procedure. All of them can have post-injury related problems. If seen early, you can manage them better, and subsequently, you can always counsel them if they need a re-enhancement subsequently. Thank you, Swapna, for getting me into your course. It was wonderful being with you. You are muted. You are muted.
Thank you very much. Thank you very much, sir. And there was one thing I would like you to mention. When would you consider an anterior lamellar keratoplasty along with flap amputation? Like in the first patient, you didn't do a keratoplasty, you let the epithelium grow, and in the second patient, you advocated one.
Because, in the first patient, the flap was totally wrinkled, and there was an epithelial ingrowth also. And almost from the periphery from the flap where it got dislodged, entire stroma was well epithelialized, and the corneal parameters were quite okay on that particular area. So I thought if you just amputate and take away the epithelial ingrowth and see how this patient does subsequently, we can plan out lamellar procedures subsequently if needed. most of the time the patient does well without any procedure also. Little bit of refractive error which will be there, which can be corrected by either glasses or contact lenses. So if I have a little more wrinkling, which is quite fibrous, and epithelial ingrowth, which is quite large, I may not do a lamellar procedure there, because you may have a epithelial ingrowth coming up in those cases also. The other case had actually a scar formation because of a knife injury, which was running through the flap and also into the anterior part of stroma underneath. There I had to do a lamellar procedure as such, because just doing a amputation may not would have helped that particular patient. So I would say if you have a lot of ingrowth, the flap is totally damaged, and the other area of a stroma is getting well epithelialized and looks quite healthy, their simple amputation might work out. Also, if you have a little bit of melting happening, then also amputation first, wait, and if needed, you do a second procedure.
So does it also depend on the thickness of the flap, the initial flap taken?
It may not depend on initial flap. It will depend on what is the stroma, the remaining behind. That is the remaining stroma is important. If your stroma is less than 250 microns, around 220, 230, then your lamellar procedure has to be done in those cases. If your stroma is 300 plus, then you might leave it and see how the patient does subsequently.
Thank you very much.
Yeah.
Now we move on to Dr. Mahipal Sachdev. He would be talking about intraocular pressure rise in both phakic IOLs as well as LASIK procedures.
Thank you very much, Dr. Swapna, for having me in your course. And it's always a pleasure being there. Well, I'll be talking about both the commonest performed refractive surgeries, and that is the ICL and the laser vision correction. And one of the problems in both of them could be a rise in the intraocular pressure that we have to see. The morbidity of glaucoma among myopes as such is 2 to 3 times more prevalent than in the general population, and majority of the patients that we are correcting by laser vision correction as also by the phakic implants are myopes, and therefore we have to be careful that we do not compound their problem. Now let us look at the two things first. First is the laser vision correction, and then I'll go to the phakic implant. In laser vision correction, the only reason for the pressure going up is actually the steroid drops, which are commonly used. Those surface acting steroids are more often used, and they are used for a smaller time. We need to use the steroids for longer periods when we are doing surface ablation. That is the PRK or the trans PRK that we are doing. Now, also there are several studies which have shown that patients with high myopia have a greater risk of being steroid responders. That is there. So there is no way that we have tested out whether they are steroid responders or not. So we are commonly using steroids in all our post-op cases. And the manifestation of steroid-induced glaucoma is similar to primary open glaucoma, except the fact that the pressure tends to rise very significantly at times. Now, myopia as it is more vulnerable to elevated IOP as regards damage to the optic nerve head. Now, one of the common things that happens when the pressure tends to rise is that the patient comes back to you and comes back suddenly saying that my vision has gone down. I was seeing clearly after the surgery, and 2 weeks, 1 week, 3 weeks after the procedure, the patient says that my vision has suddenly gone down. And then what happens is that if you are a novice, you will put that patient on a slit lamp, see, and you will get like a haze. And this is similar to the picture of the DLK, and often this mistake has been done that it is DLK and you start putting more steroids onto the eye, and that is something that is going to cause a problem, and it is going to be, obviously, apart from being ineffective, it will aggravate the corneal haze. Now, Goldman applanation tonometer is the gold standard for IOP measurements that you have. And because it is based on the modified imperfect formula, the important thing is that when you have done the laser vision correction, the cornea thins out, and the pressure reading, therefore, the principle that is there in the imperfect is that it assumes that the cornea is dry, infinitely thin, and perfectly spherical surface with a diameter of 3.06 millimeter and the CCT of about 520 microns. And the thinner the cornea leads to an underestimation of the IOP. And this table, you need to know that when you're looking at the pressure, so sometimes you should not miss out the pressure. One is the confusion with DLK. The second is the IOP correction that you are not doing. because the patient's cornea has been thinned out, and if you don't do the IOP correction, so you might say, okay, the pressure is 18 or 20 and there is absolutely no problem. So you have to have this correction table in your mind, that if your corneal thickness has gone down in this particular case, if you have done a correction of 8 diopters, you will have to add a +7 or a +6. Now, also what happens is that the corneal flap interface fluid after LASIK, that also caused a lower IOP reading, and that could mask a dangerous elevation in the IOP, because whenever the pressure goes up, the interface kind of has fluid coming into the picture, and that is the problem. And we have also personally also reported interface fluid syndrome, and that could last for long, which has been reported by these Chinese, but in our case it tended to settle down, and that is something which can again cause a fallacious low reading of the IOP. Now, the treatment obviously is that there is no specific protocol. It will depend on the pressure, but these steroid responders respond very well to anti-glaucoma therapy. If you have diagnosed it well, you have just given them acetazolamide, you have given them few drops, they will next day they will clear up, and they will tell you, the patient comes back with a smile in their this thing. You just need to do the stoppage of the steroids and to give anti-glaucoma treatment that is there. So that is all that I'll wish to say, the common fallacies of diagnosis and the treatment, and why you get it in post laser vision correction. Now let us come to the phakic IOL, and there are again the steroid responder is one of the things, because there also you are giving steroids. The number of cases that have been percentage has been reported as high as 0.8 to 26.2% that is there. So first thing is to prevention is by sizing the ICL or the phakic IOL in the proper manner, because if the vault is too high, under those circumstances you are pushing the iris up, and the outflow channels are therefore are going to be compromised, and that is the biggest problem. Gonioscopy should always be done before you are doing a patient for an implant. And you should also look at the horizontal white to white. There are obviously several theories as to whether you do a UBM, whether you do a pentacam, or you do a caliper, but majority of us use a caliper that is there. Now, the position of the ICL in the ciliary sulcus, that increases the risk of non-pupillary block. So it's not an angle closure glaucoma, it happens, but the whole thing is pushed up, that is there. Pigment dispersal, if you have been poor as regards your surgical equipment and you have pigment dispersing, that is the problem. Design of the ICL is also important. Now, almost all the phakic implants are having a centraflow or a central hole, by which could be 360 microns, or there could be paracentral holes also. When the companies came out only with paracentral holes, I would still do a peripheral iridotomy and not leave it, but a centraflow, you don't need to do a peripheral iridotomy in these cases. Now, these eyes would therefore, apart from the compromisation in the outflow, also the steroids are there, and they become therefore more prone to an angle to the pressure going up. Now, pupillary block can also be there, which obviously, if you have not done a peripheral iridectomy in the older versions, or where you don't have a central flow, that is going to be a problem. So always we used to do a peripheral iridotomy in these particular cases, that is there. An inverted phakic IOL will cause cataract if you put it upside down, but it is unlikely to cause glaucoma. But the inflammation that can be induced and the iris chafing, etc., that is there, that can cause a problem. Now, this is one of the cases. 34-year-old male patient is using bilateral contact lenses, wanted refractive surgery. Pentacam was 512, but the power was very high, minus 10.5, 12.5. And the corneal thickness, pentacam was 512, and the corneal thickness on OCT was 477. So preoperative parameters were fine. There were no echoes in the anterior or posterior chamber. Angle is open 360 degree. White to white measurement was done. Both eyes, this is the older version of the IPCL, and both the eyes, YAG iridotomy was done. You can see the YAG iridotomy. There is some pigment dispersal that has happened. And after the implantation, you can see that the pressures went high. 11 day, 13 day, 14 day, 15 days, and the pressures were not controlled despite full medication. This is the anterior chamber analysis. You can see that the vault seems to be all right. And this is 375 vault. So it is actually not a high vault at all. 13 day the vault actually tended to keep on going up. Now, what is the reason? Is there some hydration in this material, or what is happening? The vault to start with was fine, but on 13th day it kept on increasing, and the pressures went up at that time, and the corneal edema won't subside. Acetazolamide, because it was a vault, and we didn't, the steroids were continued as loteparednol instead, and IOP, despite full medical management, could not get under control. So despite all this, maybe we could have thought of stopping the steroids, but then this is what the condition looks like. And we will go ahead and this is the entry that one is doing. You can see that there is no central hole. These are paracentral holes, and I said that I do not believe in these paracentral holes giving you, because they touch the paracentral and they're below the iris. So one goes in and removes this IPCL. You can see that holding it, nudging it out, and then under those circumstances, just doing holding, grasping it, and it can easily be pulled out from the incision that is there. And then just remove the viscoelastic which is there. And you can see that the IOP normalized on 3rd day post-op. So it is not a steroid-induced glaucoma. I really can't say as to why the vault kept on increasing and why the pressures were so high. But this is what it is. The etiology and management is being discussed by this paper by Dr. Somshila, Jagdish, Praveen, etc. And what they said was that the mean intraoperative angle, this is the age that is there, male, female, refractive errors, which is there, gonioscopy, 15, 3 eyes had increased, trabecular meshul pigmentation, and the angles were, however, open. Anti-glaucoma was the last follow-up. You could see that they also had a reasonable number of patients, but I can't give you a specific reasons as to why I had, because there were no pupillary block, as they said. There was one case with the malignant glaucoma. So these are complications of glaucoma that have been noted with an implant, because you are crowding the anterior chamber and putting a lens, and there could be various mechanisms which can work for the rise in the intraocular pressure. Retained viscoelastic square and overfill could be one of them, especially if you are using viscode, etc. Pigment dispersal, and you could see the pigmentation on gonioscopy. Increased high vault is something there. Long-standing high vault can definitely cause peripheral anterior synechia. Oversized ICL, need for a good preoperative evaluation, because if you oversize, the vault will go up. Oversized ICL would cause excess vaulting, and if it is more than 750 to 1000, you definitely need to take out the lens, and this can be confirmed by the ASOCT. Pre-existing juvenile open angle glaucoma needs to be ruled out, and in very few cases it has been reported that malignant glaucoma can be there, and that diagnosis can be made in the absence of a pupillary block and excess ICL vaulting, and the ultrasound B scan has ruled out suprachoroidal hemorrhage. So that is when you will call that malignant glaucoma. Ciliary body irritation and inflammation by the sulcus placed ICL has also been known to cause anterior rotation of the ciliary body. So this has been a hypothesis that has been proposed by the same group from LVP, that this is possibly the reason that the ciliary body irritation and inflammation by this lens led to a rotation of the ciliary processes, shallowing of the AC, and aqueous misdirection into the vitreous cavity. So this has been one case that they have reported about malignant glaucoma. Steroid response, as I told you, can happen, and this would require stoppage of steroid and anti-glaucoma medication. So to sum up, I would say post-operative steroids and underestimation of tonometric IOP are extremely important considerations, specifically in the laser vision correction. Keratorefractive surgery influences the accuracy of the measurement of the GDX. That is something also important of the RNFL, but there is no significant change in the RNFL measurements after LASIK using GDX apparatus that is there. Glaucoma medications in the management of patients who have had keratorefractive surgery are similar to the medications used in other glaucoma patients, and with newer models of Centraflow, the problem of having incomplete PI or a pupillary block, etc., that may not be there. However, all the causes of IOP would still be a problem, and that you need to look at in these particular cases. Thank you very much for your kind attention.
Thank you, sir. Thank you very much. That covered, I think, both LASIK and picky IOLs, and was very exhaustive. Now we move on to corneal infections that may happen post refractive surgery, and Dr. Namrata Sharma would be talking on that. Ma'am, over to you.
Thank you. Thank you, Swapna. Thank you for making me a part of this wonderful instruction course. And I would be talking to you about the post-refractive surgery keratitis. So this especially becomes important because of the fact that this is a cosmetic surgery, and infections have been reported, and the series that I would be showing you is way back from 1998. So it doesn't mean that you could have them, but it means that this is a possibility. And the cases have been referred. A couple of cases were at our center in the initial days, but almost all of them have been referred from peripheral centers. So So this is the first case that I would like to draw your attention to, and this is a case of post-RK wound Hessen's with staph epidermidis keratitis. And this case, we had to give, and this responded to antibiotics, and a Perstrin suture also had to be applied to it because of Hessen's. Then this was a 20-year-old male rubbed his eyes with unclean fingers due to strep pneumonia, and concentrated 5% tobramycin plus concentrated 1.3 cefazolin was given, and this healed with the help of the scar. Each of these cases that I'll show you are actually already published, and this healed with the faint scar. Now this was a case of Pseudomonas keratitis after LASIK. And again, Pseudomonas is a devastating organism, but we were still able to treat it. And this was, it is important that you take a scrape in all these cultures, and this again responded to therapy. Then this was a case of E-LASIK, which was done at our center only, and the patient had dropped off the contact lens, and she put the contact lens again from the floor, and I think that is what caused the microbial keratitis. So 24-year-old female with aspergillus, which was grown, and again, because of the healing, the best corrected visual acuity was 618. Now, this was a case which was diagnosed as mycobacterial keratitis, and you can see that there is an infiltrate there, and it did not respond to any treatment. So we had to, we realized that the drugs are probably not penetrating, and we had to partially amputate the flap. So that is to say that you may have to resort to amputations of flap if the infection is not responding. So this is in the post-op period, does heal with the haze. Now, this was a case again which was referred to us, and this had a edematous flap, 22-year-old female with a buttonhole flap, and when we had to scrape the bed as well as the undersurface, we found Staph aureus. But again, it is very difficult that such a case would ever heal. So you have to completely amputate the flap. So this was a case in which complete amputation of the flap was done. And only when we amputated the flap completely by secondary intention, it healed, and notice that the vision has dropped down considerably, 6/60 visual acuity. Then this responded, of course, to concentrated tobramycin and cefazolin. Now, this was a case of post-LASIK infectious keratitis, which came to us, for which again flap elevation was done, and we tried to do scraping, and then finally it did not heal. And when we did send the button for histopathology, we found that there was alternaria, and because it was an atypical organism, probably that's why we were not able to nail it down, and we had to do a penetrating keratoplasty. So can land up into disasters like this. And this was a case, even after collagen cross-linking, this was the very first case that we had. And we had to do a short suture biopsy for this because this was a complete epithelial abscess and we could not do a scrape. Now, this was again a case which was referred from outside after epileptic surgery. This eye, left eye was like this, but the right eye was PL plus PR inaccurate. And we took a chance. We thought, let's do therapeutic keratoplasty. And by the time she came on the table, she was completely perforated. So we encompassed the trepanation 1 millimeters more than the exudates. And these exudates were all removed. And this is a membrane which is present there, and it started to bleed. But when it bleeds, that means the underlying tissue is quite healthy and not necrotic. And then a 12 millimeter graft was taken and was sutured with 10-0 monofilament nylon sutures. And the patient did well in the sense that the infection, the patient did well in the sense that the infection did get controlled, but the quality of the donor cornea was not that good, and so we had to do a penetrating keratoplasty for her again, a second graft, and she now reached 618 in that eye. So that is to say that even if the PR is inaccurate, one should not lose hope, especially in the early, when they have early infections, because it can get accurate. Now, this was again a very unfortunate case, which was again referred to us. This case was referred to us infectious crystalline keratopathy. We thought it was mycobacteria and we started to treat it. Every time we would, in fact, first we thought it was probably herpes because no organism was there. So every time we would give steroid, she would respond, and finally the infection increased, and then we did a graft. In that graft also there was recurrence. And then we did another graft. Recurrence occurred in this therapeutic graft, and we had to do glue for this patient. And this perforated glue application was done for a perforation in the therapeutic graft. And finally, we had to do a second penetrating keratoplasty, but the lens popped out during the surgery. So the patient became aphakic and had secondary glaucoma and has a vision of 618. So you don't want such mishaps to occur after a seemingly okay cosmetic surgery, and that is why one should take every precaution that such kind of infections don't occur. Now, this was, of course, radial keratotomy case, panophthalmitis, referred to us many years ago with Pseudomonas aeruginosa, PL negative. So this is also a possibility which can occur. So the idea was not to scare you with these cases, but the idea was to make you aware of these cases. So I showed a video to save some time, but these are all documented. This is important that whenever you have a post-LASIK keratitis, always suspect mycobacteria, and this could be present as single or multiple infiltrates, snowflake, cracked windshield-like appearance, and you may have to amputate such flaps. You immediately, if it is not responding, then Zeal-Nielsen stain should always be done for microbiology, because that can only pick up mycobacteria, and the medical management is entirely different. So it's clarithromycin 1%, and you might be treating with patient with moxifloxacin. It responds only partially to it, and oral clarithromycin. And sometimes you may have to amputate the flap. So you will continue topical medications for about 3 to 4 months and systemic medications for about 2 months, because this is a very resistant organism. So I think I've shown you all these cases. This case I wanted to show you was post-intact keratitis, and we had to again treat it. So this is just to show that you might have to do optical keratoplasty some of the times. So this is post-intact keratitis, how we manage the infection. So this was a
in
case.
Cases of keratoplasty, decentration, persistent.
So there can be a lot of problems, but this was a case which was referred to us, and the patient actually had only intacs was done for this case, and the patient only had redness and watering, etc. to begin with, but soon developed frank infection. And best corrected counting fingers decreased, and when the patient came, the patient looked something like this. So deep infiltrates were present in the superior ring, and microcystic corneal edema was also present. Diffuse punctate epitheliopathy was also present. So we finally had to remove these. We did try to treat it with the antibacterials and the antibacterial agents after doing a corneal scrape. But we finally had to remove this because the situation, it melted still further. And sometimes it can get a little tricky as to how you will remove it. And the best thing is that you use either a needle or you use a Sinskey hook to remove the intacts. So the patient was on cefazolin and tobramycin, as we normally give for infectious keratitis. And this is the way it is being removed, because in the edematous area, you may not be able to see it. So the best is that you just remove it from the edematous area with the help of a Sinskey hook after looking at the edge from where it has to be removed. And here we've actually used a needle, because this was very much inside, needle to thread it and to get it out. And subsequently, the other one also you should not leave, because that can cause the infection to spread. So the organism was Staph epidermidis, which was sensitive to vancomycin, and so we continued to give that. And then finally, it healed with the scar. So this is 12-week scar, and then we had to do a deep anterior lamellar keratoplasty to visually rehabilitate the patient. I will not go into the details of how a deep anterior lamellar keratoplasty is done, but this is how the patient looked like at the end of the surgery and in the post-operative period. Although the patient does enjoy a visual acuity of 612 even today, but such calamities can happen and they should be avoided. So thank you very much for your attention. And if there are any questions there, I would be happy to take them.
Thank you very much, ma'am. That formed a lot of cases, a lot of things that a novice will never see, most probably, and I hope they never do. But especially that, yeah, ICRS infection and all the radial keratotomy infections, because that's not done nowadays. Thank you very much.
Thank you so much.
So now we move on to our next speaker, Dr. Unikrishnan Nair. So he's a VR surgeon, and he'll be talking about posterior segment trauma following refractive surgery.
Thank you, Dr. Sapna, for the kind invitation, and it's a pleasure being the odd man out over here. So I'd like to.
I was wondering what is Dr. Unikrishnan doing here.
Okay. So anyway, I will just start my presentation. Yeah.
I'm glad to be a part of this instruction course, and the topic I'll be giving you is posterior segment complications after refractive surgery. There are certain pertinent questions that we have to deal with. First being, does having a refractive procedure predispose to retinal disease? And some of the retinal complications that you can see after a refractive procedure include the formation of retinal tears, retinal detachment, presence of retinal hemorrhages and macular hemorrhages, development of a macular fluid, serous macular detachment, the presence of a choroidal neovascular membrane, and even reactivation of ocular toxoplasmosis has been described. Now, the most ominous of these could be definitely the occurrence of retinal detachment. There are multiple studies that have happened which make the incidence, as you can see, from as high as 0.25% by a large study by various monitoring. And the development of retinal tears and RD has been noted 14 hours, as close to 14 hours after LASIK surgery, but a large study placed the common occurrence within 3 months. The presence of retinal detachment has been described after radial keratopathy, refractive procedures, refractive lens exchange, and phakic IOLs. The study by Ruiz Moreno could be a very high incidence at 4.8% after phakic IOLs, but a much larger study by the Arivalo et al. Group with low incidence of RD after implantation of ICLs at 0.7%, and in one particular group of lenses at 0%. This is what we have to realize, is that the yearly incidence of detachments has been estimated to range from 0.015 to 0.075 in 10 population. The Moreno et al. Group had pegged in their study at 0.36% with a mean occurrence of retinal detachment at 34.6 after studying over 5,000 patients. The Arivalo et al. Study has placed the incidence in a previous study of theirs at 0.04, 0.05%, within the range that we mentioned for the general population. This was a study of nearly 12,000 patients. And there was a yearly increase in the incidence, and which became nearly 0.2% after 10 years after the procedure. So, interesting things in this particular study was that the average age of retinal detachment after LASIK was nearly 42 years. A slightly elderly age group than the typical age group for this 2 outcomes. And what was also interesting that no patient developed attachment who had previous prophylactic laser lesions. The total the incidence of all retinal pathology in that study was 0.05 to 0.19%. So it is seen that the incidence of retinal detachment after refractive surgery is generally much lower than the general population numbers. And you can probably attribute this to all laser patients having good direct fundoscopic external depression, followed by pre-treatment of many of these for this. So, though there are no specific indications as to whether we should treat basic patients different from any other person who wants to have peripheral agents. There is no hard evidence to say that whether prophylactic treatment is indicated, given the general tendency for myopes and patients with higher refractive errors to have retinal pathology. It might be prudent to treat these meticulously. So, retinal detachment happening after lens-based refractive procedures is a slightly different with much higher rates, ranging from 1.5% to 3.28% in some studies after lens-based refractive procedure. So the question comes, does the management of retinal pathology alter the backdrop of such refractive surgery? So the intraoperative management issues we could be dealing with is the visualization, will the visualization be affected, whether the implanted lens would slip out of its position by the somewhat vigorous maneuvers that we believe that the surgeons will do, and whether it is mandatory to remove the implanted lenses during surgery, and we'll discuss some other complications also. So I'm just going to start with this video. So this particular person who had a retinal detachment, we started off by implanting, putting around a bell couple, which went on well. Why I say went on well is that after we see that the ICL is still in position after the bell couple is placed, it hasn't slipped out or hasn't caused any issues. So this particular patient had a giant retinal tear after trauma, after a 45-year-old was implanted. You can see the large leaflets of the GRP, and we proceeded with the vitrectomy, and you can see the edges of the GRP. It's a significant thing. So the vitrectomy procedure after the vitrectomy was completed. You can see the detached retina, and the anterior leaflet of the retina, which is freehand, was removed. The edge of the GRP was cauterized marked, as you can see here. PFCL is now being injected to flatten the retina. It's a small PFCL bubbles. As the PFCL increases, and you can see as the procedure increases, as the PFCL bubble increases, the retina is being pushed flat. So far, the visualization has held good, and the presence of the ICL has not caused any difficulty so far. So once the PFCL has reached the maximum, you can see the laser being applied to the edge of the GRP. Laser marks the laser goes all around, and then I'm putting a really good 3 or 4 layer lasers to hold on the retina. And once the laser is complete, we'll just try out the edges of the horns of the GRP just for additional security. So that's the cryo marks coming to the edges of the GRP, the horns of the GRP. And there is no problems with the interpretation of the blood resistance, with any problem with the ICL position or anything. And after now, see the air fluid air exchange is being done, PFC is being removed. And after the PFC is the last amount of the PFC has just been removed. Now oil is being injected. And the ICL held through all the procedures, including the belt buckle, the indentation, some of the complications that can happen even in the posterior, in the post-operative period is AC shallowing, especially if you use tamponade with oil, displacement of the lens can happen. This particular patient we operated developed anterior ischemia because of a high volt ICL, the presence of a buckle, and also the presence of oil inside. Probably so we hypothesize that it caused anterior ischemia for this patient. Cataract formation and glaucoma are also complications. So the last question being, what are the precautions the retina surgeon can take to ensure a good and accidental outcome from the retina point of view and accidental refractive outcome? That is that we do as minimal a job as possible, cryopexy, pneumatic retinopexy when possible, and vitrectomy when essential. Avoid the use of a scleral band or any procedure that tends to change the shape of the or length of the blade. An option that if you have to use a scleral band would be to remove it after a couple of months before the elongation of the blade comes upon picture. Other retinal pathologies that can happen due to increased IOP by activation of the section could be the development of lac attacks and macular hemorrhage and CMD and IOPs. The same would happen in patients with angioid streaks and connective ruptures if they undergo LASIK. Stage 1 macular holes can clearly proceed to full thickness macular during the maneuvers of the procedure. To summarize, patients undergoing refractive procedures require retinal evaluation thoroughly, treatment of all peripheral lesions. Older patients may be more susceptible to develop retinal detachment, and the incidence of retinal detachment decreases with time, but generally the incidence is not much more higher than that of the incidence of retinal complications. The surgical management has to be always subtle to avoid maneuvers that change the refractive surface. ICL removal may not be necessary or mandatory and probably can work around instance. Visualization may be hampered by cataract formation and flap displacement. Issues with tamponade have to be anticipated, like shallow or BBC, and posterior complications may include cataract formation and anterior. Thank you very much for your patience.
Thank you for the chance to present the ICL.
Thank you very much, Dr. Unni. So I think we have covered most part of post-refractive surgery complications. Thank you very much, all the panelists, for being part of this IC. Thank you.